Welcome to Dental XP. I'm Dr. Maurice Salama, and I'm going to be sharing a very interesting approach to a common dilemma in the posterior maxilla. This patient presented with a deficiency on the buccal aspect of the maxillary left second bicuspid. Due to previous trauma and injury, he had lost some of the width of this area. And this is what we would classify as a type 2 defect in the ridge. Type 2 defect is one where buccolingual deficiency is present, but not one that constitutes a vertical deficiency. You can see the interproximal tissue and bone levels are adequate, and we're going to attempt to treat this case in a very aesthetic and efficient manner. What we are going to attempt to do here is utilize a one-piece implant, but one that is actually angled, a 17-degree angled implant that will allow us to engage the palatal bone and avoid further augmentation of the buccal deficiency in a staged approach. Obviously, multiple methods of handling this deficiency, and buccolingual deficiencies can be handled with GBR, with bone grafts, and as well as tissue augmentation, but they're very predictable. What we're going to attempt to do here is take the crestal incision and move the keratinized gingiva that remains towards the buccal aspect. In this case, we're going to be utilizing a Zimmer one-piece system, and the initial pilot drill with a very sharp pointed tip is going to engage the good and healthy palatal bone available for implant placement stability. You can see an angled analog at this initial pilot drill to let us know whether or not this angulation would be acceptable for this patient's occlusion and allow us to place the collar of the implant and the direction of the abutment in the right position. With a one-piece implant, it is very important to make sure that the restoration, as you see here, the temporary restoration, would be in line with the future position of the one-piece implant. One-piece implants really require exceptional control by the surgeon to place the implant exactly where it needs to be, as you don't want or have no ability to alter the abutment very, very significantly. Most of the time when we use these systems, we check it before going on to the 2mm twist drills. All of this has to play directly and making sure that we're going to end up with the right positioning of the implant. Now, what's very interesting here is the angulation of the twist drill is going to be at 17 degrees to the normal direction of a twist drill, because we're accepting the fact that we don't have the amount of bone present on the buccal to retain a normal positioning of the twist drill. And we're going to have the 17-degree angulated one-piece implant. The unibody implant from Zimmer is going to manage this angulation change for us. So you can see that the drill actually appears like it's coming out through the buccal aspects of the adjacent teeth. And you can see now the one-piece angled, 17-degree angled implant being inserted. And as it's rotating, you can really see the significant angulation of the abutment of this one-piece implant. But what's very interesting is that the rotational axis does allow us to rotate this implant in between the adjacent teeth without making contact. This is a very good picture showcasing the direction of the adapter, placement adapter of the implant versus the actual direction of the abutment of the implant. What's nice about this system, many others, is that when you have components that facilitate easy temporization and restoration. This is a temporary cap that can then be luted to a polycarbonate crown the day of insertion, and we reline this with quick cure acrylic. So we gain the margin utilizing a temporary cap that fits and is manufactured to fit down to the margins of the abutment. And remember, again, this is a one-piece system with no screws. The analog here, made for the one-piece implant, 17-degree, is then fitted to make sure that we have good adaptation, and we will now shape the temporary out of the mouth on the implant analog. We then put down the temporary to make sure that it fits down to the shoulder of the one piece, and we're going to use a roll technique to enhance the thickness of the soft tissue, basically hiding the fact that there was ever a buccal-lingual deficiency. And this is a technique that was really first discussed in the literature by Dr. Leonard Abrams for ponic augmentation and ovate ponics back in the early 70s. We're now going to take the two pieces of keratinized gingiva that's folded, and utilizing a vertical sling mattress suture, we're going to adapt this additional soft tissue to our immediate temporary restoration. And this will allow us to manage not only the immediate temporization of the case, but also manage the aesthetics as we've thickened the tissue on the buccal aspect for contour and, of course, to hide the underlying titanium. You can see this early on. We had to open the case up orthodontically to fit the implant, and then the placement of the implant just slightly above the crest, and then when the final crown was placed at approximately 6 months. Taking a look at this on the day of insertion, you can see the one piece with the pre-machined anatomic collar, the final all-ceramic crown. This was fabricated by Dr. David Garber, and upon insertion, you can see a very nice aesthetic reconstruction of a deficient space, all done in one procedure. You can see the soft tissue has lined up very nicely with the adjacent teeth, and we've taken care of the deficiency and the bone defect, managing it with soft tissue manipulation as well as an angulated one-piece implant. I hope this gives you another option in your toolbox for dealing with these types of cases, and I thank you again for being with us at Dental XP.